Good evening, and welcome to the Cure HHT webinar series. My name is Nicole Schaefer, and I'm the Director of Professional and Medical Programs for Cure HHT. I want to welcome you to this evening's webinar, An HHT Diagnosis, What Does This All Mean to Me and My Family? A few reminders. Tonight's call is being recorded and will be posted on the Foundation's website. After tonight's call, you will receive an email with a short survey. Please complete this so that we can better serve you in the future. Except for the presenters, everyone's phone or microphones are muted during the webinar to help reduce the background noise. If you have a question at any point during the presentation, please type your question in the gray control panel on your screen. Your question will come to me and I will ask them to our presenter during the second half of the call. We ask that you keep your questions more generalized so that the answer will benefit everyone. Now it is my pleasure to introduce our speaker. Dr. Justin McWilliams obtained his Bachelor of Science in Biology at Truman State University in Missouri, where he graduated valedictorian and summa cum laude. He then attended the David Geffen School of Medicine at UCLA, where he received multiple letters of distinction and was selected for the Alpha Omega Alpha National Medical Honor Society. After completing a transitional internship at St. Vincent's Hospital in New York City, Dr. McWilliams returned to UCLA for his radiology residency. There he served as chief resident and also received awards for outstanding radiology resident and outstanding graduating senior resident. He then remained at UCLA for interventional radiology fellowship, at which time he also served as chief fellow. Upon completion of his fellowship, Dr. McWilliams accepted a faculty position in the Interventional Radiology Department at UCLA. There, he splits his time between angio and interventional procedures and cross-sectional interventional procedures with a focus on HHT. Together with Dr. Gary Duckwaller, Dr. McWilliams founded the 10th HHT Center of Excellence at UCLA in 2010. And now runs a very active center with comprehensive HHT diagnosis and treatment. Dr. McWilliams was recently the recipient of the Cure HHT Robert I. White Young Clinician Award. Dr. McWilliams, we thank you for your time tonight.
And thank you very much, Nicole, and thank you to the Cure HHT Foundation for helping arrange this webinar. And thanks to all the attendees for being here. This is really going to serve as kind of an overview of HHT, and my goal with this next hour is to try to make everyone more knowledgeable than 99% of people out there, and most likely you'll be more knowledgeable than 90% of doctors out there just after seeing this webinar. We'll really try to cover a broad swath of what HHT is all about, the testing that we can do, the treatments that we can do, and so on. Well, the summary of this talk will be starting an overview. We'll talk about making the diagnosis, talk a little about the centers of excellence. A lot of people will be interested in controlling symptoms of HHT as well as screening and treatment of ABMs. And we'll finish up with speaking about some precautionary measures as well as some links to other medical conditions. A lot of you already know that HHT is also known as Osler-Weber-Rondeau disease, and it's a genetic disorder of blood vessel formation. The incidence is estimated to be about 1 in 7,000. I stole this quote from Dr. Bob White. He always calls it an equal opportunity disorder, and what he means is that HHT affects all races and ethnicities with fairly similar incidence. It's a genetic disease and it's autosomal dominant, and what that means is that it doesn't skip generations, and about 50% of the offspring of a HHT-affected individual will also have HHT. So if you look at the family tree of an HHT family, it'll look something like this, where the squares and circles that are shaded in black are the affected members of the family, and the ones that are white are unaffected. And you'll see that about half the family members are affected, and that it does not skip generations, that someone in every generation is affected. Historically, the diagnosis was made based on clinical criteria. These are called the Kurosawa criteria, and there are 4 of them. The first is spontaneous and recurrent nosebleeds. Second is telangiectasias. Third is the presence of arteriovenous malformations. And fourth is having a first-degree family member with HHT. That could be a father, mother, brother, sister, son, or daughter. And those 4 criteria, if you have 3 or 4 of those criteria, you definitely have the diagnosis of HHT. If you have 2 criteria, you're in this sort of uncertain, possible, or probable HHT. And if you only have 0 or 1 criteria, it's unlikely that you have HHT. There are some limitations of this clinical diagnosis, and the limitations mostly lie with younger patients. Because nosebleeds often don't start until around age 12, and the telangiectasias often don't appear until about age 30, these clinical signs can be unreliable in children and young adults. And also there's a large number of patients that only have 2 criteria that puts them in this possible or probable category. Unfortunately, within the last 10 or 15 years, there's been a genetic test that's become available, and the genetic diagnosis can be made in about 90% of HHT patients. We test generally for 3 genes, and those genes are indiglin, ALK1, and SMAD4. The indiglin and ALK1 together cause about 90% of HHT. SMAD4 is much rarer, only about 1%. And those correspond to the HHT types. So indiglin causes HHT type 1, whereas the ALK1 mutation causes HHT type 2. And there are some differences, which we'll get into, whether you're a type 1 or type 2 HHT. This is just a look at the chromosomes, and indiglin is on chromosome 9, outlined by red. The ALK1 is on chromosome 12, outlined by blue, and the SMAD4 is on chromosome 18, outlined in green. The way that we perform genetic testing, and I try to do this in almost all of my patients, is that we start by testing someone in the family that definitely has the diagnosis of HHT, meaning they fit the Kurosawa clinical criteria. We can be quite confident they have HHT. And the reason that we start with them is because we want to find out what is the mutation that's causing HHT in this particular family. Once we've identified what the mutation is in the family, then we can test any of the other possible at-risk family members with a much simpler test where we test only for that specific mutation. And so in that way, we can very confidently assess whether any other family members also have HHT. There are a few limitations of the genetic diagnosis. There are some people, about 10%, who definitely have HHT, meaning they fit the clinical criteria, but they don't have a mutation detected on genetic analysis. And those patients likely have some other genetic mutation which has not yet been discovered. It's also possible that you can get something called a variant of unknown significance when you have your genetic testing done. If you have a VUS, or variant of unknown significance, it means there's an abnormality of the gene, but they're not certain whether that abnormality of the gene actually causes HHT. And so it's a sort of a gray area where usually we can interpret that in the context of the genetic testing of other family members and try to determine whether that VUS is actually causative of HHT, but it does introduce some uncertainty. And there are some downsides as far as cost. Now, fortunately, I've never had much trouble getting this approved by insurance, so I've always been able to get it covered by insurance for my patients, but the cash cost can be quite expensive for the initial testing, around $2,500, and then for the mutation-specific testing, around $250. Now, unfortunately, there's not much knowledge about HHT, even among doctors, as I'm sure many of you have seen as you've seen doctors about your illness. But fortunately, there have been the formation of multiple centers of excellence around the nation and around the world that basically are sites where HHT knowledgeable physicians gather and from all different disciplines and can see HHT patients and will know how to diagnose and treat those patients appropriately. And these stars are just the locations of the HHT centers in the US and Canada. And my center at UCLA, which we started back in 2010, is here in Southern California. We draw a lot of patients from Central California, Nevada, Arizona, Hawaii, and Alaska. About 300 patients I follow now, and I like to think that they're coming to see me, but I suspect that they're actually here to see my very handsome co-director, Gary Duckweiler. As far as the vascular abnormalities we see with HHT, telangiectasias we see are present in more than 90 to 95% of patients. So these really, if you look at them microscopically, are tiny little arteriovenous shunts, meaning tiny little connections between artery and vein. And they involve a dilated arteriole and a dilated venule. But the way that they appear on inspection is just a red spot, usually 1 to 2 millimeters in size. These telangiectasias are present inside the nose and are the cause of the nose bleeding that occurs with HHT, and they're also present in the GI tract and are the cause of the GI bleeding. Now, the same sort of pathology, a direct connection between an artery and a vein when it's larger, is referred to as an arteriovenous malformation. So it's very similar. It's a direct connection between an artery and a vein, but these are larger and occur in organs such as the lung and the brain and the liver, and these malformations are the cause of the really severe and sudden disastrous complications of HHT, such as stroke and brain abscess, heart failure, lung bleeding, and brain bleeding. This is just a diagram, kind of an overview of all the abnormalities that can be seen in HHT. As we mentioned, more than 95% of patients will have nosebleeds and telangiectasias in the nose. Also, about 95% will at least eventually develop telangiectasias on the lips and fingertips, most commonly also the tongue and the oral mucosa. Brain AVMs occur in about 10%, lung AVMs in 30 to 40%, gastrointestinal telangiectasias in about 25%, and liver AVMs in at least 50%. So you can see it really affects many organ systems, but it was similar pathologies at these arteriovenous connections. There are some basic principles of management in HHT that I try to follow whenever I'm treating my HHT patients. And firstly, that's to control the symptoms. And nosebleeds, of course, are a very common complaint. We'll get into ways that those can be treated. Sometimes cutaneous bleeding, meaning bleeding from telangiectasias on the skin, and also GI bleeding, especially in older patients, can be a big problem. Just as important is that we screen for and treat the AVMs, especially those in the brain and the lungs. And finally, we need to manage any rare complications of HHT, which could include pulmonary hypertension, liver failure, or high output heart failure. So we'll start by a discussion of controlling the symptoms of HHT, and in this section I'm going to cover cutaneous bleeding, nosebleeds, and GI bleeding. We'll start with skin telangiectasias and the cutaneous bleeding because this is usually pretty straightforward. Telangiectasias usually have their onset during the 20s or 30s, and they increase in number as patients get older. The biggest problem is bleeding, which can happen recurrently, especially the ones in the gums and the tongue and the fingertips, areas where there's a lot of trauma, whether it be from eating or handling things. You can get bleeding, and I've even had patients where they have telangiectasias on their fingertips that where they can shoot blood across the room like a superhero. So pretty wide variability and severity. But if they are severe or if they're cosmetically unappealing, they can be treated. And most often I refer my patients to a dermatologist who has a specialization in what's called pulse dye laser. And that's a special type of laser where they can basically zap these telangiectasias and they'll shrink up. They can also be surgically excised, or sclerotherapy can be performed in certain instances, but most of the time they can be taken care of with laser. Now, those telangiectasias will often recur. In fact, they usually will recur, but if you're having a particularly troublesome one, then these treatments can be helpful. Now we'll get into nosebleeds because I know that's something of great interest to many HHT patients. And as we mentioned, over 90% of HHT patients do have recurrent epistaxis. Frequency and severity are really variable. Some of my patients just have a nosebleed or two a month that stops very easily. Other patients I follow at my center have multiple nosebleeds per day lasting hours at a time that are gushing in severity and have required blood transfusions and hospital visits and so on. Certainly, they can cause social anxiety and embarrassment, but they can also result in anemia, transfusion dependence, and hospitalization and very bad illness in some cases. And what they're caused by is really by these telangiectasias that are these fragile, thin-walled vessels that occur inside the nose on the nasal mucosa. And those telangiectasias are irritated by the movement of dry air. So particularly patients in dry climates, my patients coming from Arizona and Nevada will tend to have worse nosebleeds than those from humid environments because that dry air is what irritates these fragile vessels and causes them to rupture and bleed. The other thing that can cause bleeding is increased pressure, and that can occur in patients that have hypertension or high blood pressure, but also can occur in patients just from bending over or excessive straining, and I'm sure many of you have noticed that. And I have many patients tell me that they just can't bend over because they will always get a nosebleed if they do so. That's because of the increased pressure that's occurring on those telangiectasias. So as far as treatments, this really differs from center to center. Every center has a different sort of series of steps that they'll go through, and I can only speak from my experience. So there is a lot of similarities between the way all of our HHT experts treat nosebleeds, but I have my particular way, and this is the way that I approach a patient with nosebleeds. And I really sort of separate them into severity levels and sort of start with the milder treatments and work my way towards more aggressive treatments if needed. And so starting with level 1 are kind of the treatments that anyone can be on because they're very safe, and really pretty much everyone with HHT should probably be on them. And that's, I always have my patients, if they can tolerate it, to have a room humidifier, particularly in the bedroom, to help humidify the air and moisturize it. I recommend topical salves to moisturize and lubricate the nasal mucosa. And different patients have success with different solutions. Some patients do great with just a saline spray, like a ocean spray. Other patients do better with a gel, like air gel or nasogel. Some patients prefer a petroleum jelly type product like Vaseline, or antibacterial like bacitracin. Others prefer a KY jelly, which is a non-petroleum jelly type of lubricant. And I have had some patients mention success with a product called Ponaris, which is actually used by astronauts because I guess the air is very dry in the space station, and so they use this to help hydrate and moisturize the nose for the astronauts, but it's available on Amazon as well. And a lot of patients have success with using saline rinse, like a neti pot or saline irrigator, which will help remove the crusts and keep the nose clean. Other patients find that those actually cause nosebleeds, and if that's the case, then I don't have them use it. But it's one of those things where every patient gets to know their nose very well as to what works best for them, and so I recommend trying these products and finding which one works best for you. There is some basic pharmacologic treatment which I often recommend to my HHT patients. If you're a woman of childbearing age, the estrogen and progesterone that are present in birth control pills actually help strengthen the mucosa of the nose and can actually help prevent nosebleeds. This is a reason why patients after menopause, when estrogen levels decrease, they often have worsening nosebleeds. So we can take advantage of the estrogen and progesterone effect by putting patients on birth control pills and reducing nose bleeding in that way. And certainly if a patient is hypertensive, has high blood pressure, then they should be on medication to help reduce that. Finally, everyone should find out what their triggers are, and those triggers are not the same for everyone, but you may find certain triggers that trigger nosebleeds in you, and the ones I hear the most commonly are alcohol, particularly red wine, and spicy foods. But certainly also anything that thins the blood, like aspirin, NSAIDs, or other blood thinners can also be troublesome, and those should be avoided whenever possible. Once we've tried those treatments, if those have not been effective, then we proceed to level 2 treatments. And there are two main ones that I use here, and that's antifibrinolytic therapy and ENT referral. And it really depends on the patient which one is most appropriate. Some patients would prefer to be on a medication that they take every day, whereas other patients really hate being on a medication, would prefer to have a procedure like a cauterization done. Both of these can be quite effective. The antifibrinolytic therapy, these are specialized medications that actually make your blood clot better. They help stabilize a blood clot once it forms. And there are two of them. One's called Amicar, that's a little bit older. There's a newer one called Lystata, or tranexamic acid, which is the one that I prefer. And there's actually been a pretty recent study done on the tranexamic acid, which showed it was very effective, had about a over 50% nosebleed reduction in patients that were on it. And it does, in my experience, I found it to be very effective as well. There are some rare side effects that can be possible, including nausea, diarrhea, muscle pain, and dizziness. What patients and doctors often get worried about is, does this medication, which makes your blood clot better, will it actually cause blood clots when you don't want them to happen and potentially cause DVT or stroke or heart attack? I have not had that happen in any of my patients. I believe that that's because this medication actually stabilizes blood clot that is forming, but doesn't actually cause blood to clot. So the moment your nose starts to bleed, your body will try to form a clot to stop it, and this medication will help stabilize and form that clot, but it doesn't cause your blood to clot, the blood that's circulating around. That blood, it won't stimulate to clot. And so I think that's why we haven't seen this side effect, but I do always mention it to my patients, and if they're high risk for blood clotting, like if they've had a prior history of stroke or DVT, then we are cautious with the use of these medications. For ENT, these depends very much on the ENT. Definitely you want to see an ENT who's familiar with HHT. I tend to recommend laser cauterization, but some of our ENT physicians have used electrical cautery. They just have to be careful because too much electrical cautery can cause septal perforation and other problems. Some of the ENT physicians will use local Avastin injections, either alone or along with the cauterization, and those can be effective. And there have been some reports of sclerotherapy being used, which is injection of a detergent basically to help shrink down the telangiectasias. Select cases may be helped by hormonal therapy, and there has been some use of estrogen and progesterone, as well as a medication called tamoxifen, and that actually had a randomized controlled trial that did show some improvement in nosebleeds in about 90% of patients, which sounds great, but that comes with a caveat, and that is that the risks were relatively high, and those risks include menopausal symptoms, blood clots and stroke, increased risk of endometrial cancer and cataracts. So actually very rarely use this medication, but it is out there for patients with severe bleeding. As we proceed into even higher level treatments, there are two medications that we do sometimes use for very severe nose bleeding that's not been responsive to other treatments. That includes thalidomide and intravenous Avastin. Now, both of these medications are fairly similar. They're both what we call anti-angiogenic. What that means is they help reduce new blood vessel formation, and that's an advantage because in HHT you're having new little blood vessels. Those telangiectasias are forming all the time, and so when you're put on an anti-angiogenic medication, it can help reduce the formation of those telangiectasias and thereby reduce the bleeding that you have. The thalidomide is an oral medication. It got a very bad rap back in the 50s from it causing birth defects, and certainly it can't be used in women of childbearing age. And there are other risks as well, such as blood clots and dizziness and mood changes. So I don't use this one so much. I have used intravenous Avastin in a number of very severe nosebleed patients. It's usually given as an intravenous solution. We can sometimes give a little bit lower dose than what is used for cancer treatment, and we give it usually every 2 to 6 weeks and find a very significant nosebleed reduction in a large proportion of patients. But again, this is not a medication to be taken lightly. I often have patients come to me saying, oh, I really want to have Avastin. I hear it's great. And Avastin, don't get me wrong, is a great drug, and it's very promising in many ways for HHT patients, but there are some fairly severe side effects to look out for, and those include GI perforations, decreased wound healing, high blood pressure, headaches, and blood clots and stroke, as well as some others. So we have to be very cautious in its use and make sure we only use it in the most serious and severe patients. There's even higher level treatments than these, and that's to have your nasal passages closed entirely. The nostrils, basically the inside of the nostrils can be sewn shut, and that's called a Young's procedure. And when you don't have the movement of air across the mucosa of the nose, you basically have an elimination of the nosebleeds. And although most patients can't stand the idea of not being able to smell and reducing the sensation of taste, patients that have this done usually don't have it undone, even though they can. And the reason is because they were so miserable, they're having nosebleeds that were so severe that getting rid of the nosebleeds is such a life-changing event for them that they can live with those other effects. And so that is something to consider in very severe bleeders. And in patients who are emergently bleeding, meaning you have a nosebleed that just won't stop and you come to the ER and nothing they can do seems to stop it, we do sometimes use nasal embolization, and that involves going into the artery under x-ray guidance and finding the vessel that's bleeding and blocking it off. And we have had some patients that have had a durable response to that, but usually the bleeding will return after 6 to 8 weeks, where new telangiectasias will form and you'll be back kind of where you started, but certainly it can help patients in those emergent situations. Now for GI bleeding, it's basically caused by a similar problem. Rather than telangiectasias in the nasal mucosa, the similar telangiectasias occur all throughout the GI tract. And it fortunately affects fewer HHT patients. Only about a quarter of HHT patients are affected by GI bleeding, and usually it's older patients with age greater than 50. Most often these telangiectasias occur in the stomach and the small intestine, but they can also occur in the colon. And the bleeding tends to be slow and persistent. You don't usually have massive bleeding from these telangiectasias the way you can sometimes have massive bleeding from the nose. The way that we diagnose the GI bleeding is the patients can tell us that they have blood that they notice in the stool, or sometimes blood in the toilet bowl. Or occasionally they won't see blood, they'll see what's called melena. And melena is basically a black, tarry stool, and that's from digested blood. So if you have bleed into your stomach or your small intestine, by the time it passes all the way out, it will often have this black appearance rather than a red appearance. So that's something to look out for. But it can be seen normally if you're taking iron pills. You'll see this kind of black stool normally even without blood in the stool from the iron. So isn't this a good diagnostic criteria if you're taking oral iron replacement? Other things that patients may have is fatigue or pallor from anemia, which can develop from GI bleeding. Your family doctor will often test with a fecal local blood test, and a CBC will often show iron deficiency anemia, but to confirm the diagnosis, we usually have upper and lower endoscopy performed where they can take a look with a camera and actually see the telangiectasias. That can also be a treatment where they can do cauterization. We'll get into that. So there's a few levels of treatment for GI bleeding as well. Just like nose bleeding, this really can be very mild or very severe depending on the patient. For most patients that have small volume gastrointestinal bleeding, all they need is iron replacement. Basically that your body is made to be able to replenish your blood stores in a fairly rapid manner. And so as long as you're not losing too much blood, as long as you have enough iron, you can make enough blood up to replace it. And so usually I start my patients on ferrous sulfate or ferrous gluconate. Those are easily available over the counter. And I shoot for a ferritin level greater than 50 micrograms per liter. That's something we can check with a blood test. There are some side effects of iron. Usually they're GI effects like nausea and vomiting, diarrhea, constipation. If none of these standard formulations are tolerated, there's a heme iron, which is a little bit better tolerated. It's called prophylactic ES. And for any iron, it's usually best to take it in several equally spaced doses over the course of the day. And you can take it with food, and that will increase its tolerability but may reduce its absorption. You can also take this with vitamin C. Vitamin C will help your absorption of iron, so keep that in mind. If oral iron is not tolerated or it's insufficient, then you can be set up with a hematologist who can give intravenous iron, and this is often given every few weeks to get your iron stores replenished. And then some patients have enough bleeding that they need it on a chronic basis, where they get an IV infusion every month or so. Just like with nosebleeds, you want to try to avoid blood thinners like aspirin and NSAIDs if possible. If those treatments have not helped, then we can proceed to the next level of treatment, and that usually starts with endoscopy, where they can do cauterization, basically look for the telangiectasias that are bleeding and zap them with a little laser cauterization or argon plasma cauterization. Sometimes, in fact often, they will do endoscopy and see thousands of telangiectasias, and if that's the case, then you actually have to caution the gastroenterologist that they don't want to try to cauterize everything because they can cause a perforation. And so if that's the case, you don't want to use cauterization in those cases. What we often use are similar therapies to what we use in severe nosebleeds, including antifibrinolytic therapy like the tranexamic acid or the Amicar to help the blood clot better, or estrogen or progesterone therapy in some cases. If GI bleeding is resistant to those therapies, then just like in nosebleeds, we can use more aggressive therapies such as Avastin or thalidomide. These are the anti-angiogenic drugs. And there are not large studies to support their use, but there are case reports. And I've certainly had patients at my own center where I've used intravenous Avastin in patients with severe GI bleeding, and they have had a miraculous and fantastic response where they've recovered from their anemia and their GI bleeding has slowed considerably. And it's been a real life changer for some patients. But again, there are those side effects to be considered with both of these drugs. That gets us through handling the three main symptoms that we notice with HHT. I want to cover now the screening and treatment of the AVMs, which often you'll never know you have unless you're screened for them. And so patients often think, oh, I don't have to worry about anything, my nosebleeds aren't so bad. But the fact is that even if your nosebleeds aren't bad, you can have very bad AVMs that could potentially cause a disastrous complication. And so we'll talk a little bit about the three main types of AVMs and how we can screen for and treat them. We'll start with lung AVMs, which is very near and dear to me because I do a lot of treatment of these as an interventional radiologist. These lung AVMs are a direct communication between the pulmonary artery and a pulmonary vein. And the reason that they're important is because they bypass the normal capillary network that occurs in the lung. So normally the lung arteries divide into tiny little capillaries, which is where oxygen exchange occurs, and then the blood gets gathered up by bigger and bigger veins to go back to the heart. When you don't have those capillaries and you have a direct connection between an artery and a vein, you reduce the filtration function of the lung, and little bits of clot or bacteria that are coming up from the legs or elsewhere in your body that usually get filtered out by the lung, they can pass right through this lung AVM and get into your systemic circulation, where it can then go to your brain or anywhere else, cause a stroke, a brain abscess, etc. These lung AVMs are thought to be congenital in most cases, meaning they're often present from birth, but they can grow over time. So it is something that we have to continue to follow patients for to make sure new ones aren't growing or developing. The clinical importance of lung AVMs, first of all, can be what we call dyspnea or shortness of breath, and that's due to low oxygen levels. Almost half of patients with lung AVMs will have shortness of breath. The more worrisome and sudden and disastrous complication can be a stroke or a brain abscess, and that occurs due to of clots or bacteria through the AVMs. Over a lifetime of having a lung AVM, your chance of having that occur is about 30 to 40%, so pretty high. This pictures on the right are a couple MRI scans where you can see this brighter area, and the MRI scan is an area of a stroke, and this very bright area on this MRI scan is an area of brain abscess and surrounding swelling of the brain. Very commonly in HHT patients, you can get migraine headaches. About 50% of patients with lung AVMs get migraine headaches. And finally, about 10% will have bleeding of the lung AVM, lung or around the lung. The main way we screen for lung AVMs is with something called a contrast echocardiogram or a bubble study. Basically what happens is we inject some agitated saline into an arm vein, and those go to the right side of the heart, and then they should go out to the lung and get filtered out, and they should not come back to the left of the heart. But if they do pass through the lung because there's an AVM there, then they'll appear in the left side of the heart after a delay of 3 to 5 heartbeats. And the bubble study is quite a safe procedure. There's no radiation. You can sometimes trigger a headache or migraine with it, but otherwise it's very safe and very sensitive, so it picks up almost any AVM. But it doesn't tell you how big the AVM is or where the AVM is. So if the bubble study is positive, we do a CAT scan of the chest. And a chest CT, although it does require radiation, is the only way really to see the size and treatability of the AVMs. And so it's the next test we do after a positive bubble study. We're getting to the point where MRI may become a replacement for CT, which would be great because it would not require radiation. But we're not quite to the point where MRI is as good as CT yet, but we're getting there. For kids, the screening is a little bit different. It's very, very rare to have a bad outcome in a child from a lung AVM early in life unless they are having very low oxygen levels, or if they're having clinical signs like they're not keeping up with other kids, they're getting short of breath, they're having blue fingers or lips. If none of that's occurring, then all we need to do is check their oxygen saturation every year with their pediatrician, and otherwise don't need to do any testing at all. We usually do our first testing at age 10 to 12, and usually that's with a bubble study since there's no radiation involved. And if it's negative, we just repeat that every 5 years. If it's positive, then we do a chest CT, as we mentioned before. And in a child, if a chest CT does show a treatable AVM, we often do need to proceed with coil embolization to help prevent brain abscess and stroke and the other problems that can occur. But if it's a small AVM, we may just watch it until at least age 18 just to reduce the radiation exposure that is required for the embolization procedure. These images on the right, this is what the blue fingers or cyanosis can look like with very low oxygen levels. And then this is just some pictures of the heart, a 4-chamber echocardiogram, and then you can see all the bubbles filling all the chambers of the heart in a patient with a large lung AVM. As far as the treatment for lung AVMs, it used to be surgery, but fortunately we don't have to do that anymore. We do coil embolization, which is a very successful procedure. It's the one that I do to treat lung AVMs. Complications are rare. It's performed as a same-day procedure. You don't require hospital admission, and you have immediate protection from stroke and bleeding and brain abscess. Our goal is to include all AVMs greater than 2 to 3 millimeters in size, and the way we do that is using this catheter-like device, which is a tiny, skinny little tube that we introduce into the vein, usually by going into the vein at the groin. And we pass this up into the lung and we take pictures, and then once we find the AVM, we can block it off with a variety of devices, including fiber coils, which are the most commonly used devices, but also these specialized types of plugs or even microvascular plugs, these tiny plugs, depending on the size and orientation of the vessel. This is just an example of what it looks like. This is an angiogram we do. This is the right lung. We're injecting contrast, and we can see one vessel that's going out and forming a little sac and then a draining vein, and this is what an AVM looks like. It looks very different from the rest of the vessels in the lung that look kind of like the branches of a tree where they taper out into smaller and smaller branches, whereas this branch stays very large and never really tapers to anything smaller. That's what an AVM looks like. Once we find that AVM, we feed into it with the catheter. This is just under X-ray what it looks like. This is the catheter feeding into the feeding artery of the AVM, and now we can see the contrast passing into the AVM, the aneurysmal sac, and the draining vein going back to the heart. So you can imagine how a little clot or bacteria could pass right through this circuit and out into the systemic circulation where it would cause a problem. So I then pass a microcatheter, this tiny little 1 millimeter microcatheter, out close to the sac, pack this area with coils, and now we're injecting contrast. We can see that that column of contrast stops, doesn't make it past the coils. That way we know we've completely blocked this AVM, and that patient will most likely not have any further problem related to it. Just a second example, newer one, small AVM in the left lung, very similar appearance, pass the microcatheter into it, and here we used a little microvascular plug, and injection of contrast. This whole video shows that the contrast is not going past the plug, and that AVM is fully taken care of. Once you have a lung AVM treated, we do follow-up. Usually at 1 to 6 months, I'll get a CT angiogram of the chest with contrast. That should show that the aneurysm sac and the draining vein have regressed. And then we have to follow it about every 5 years after that, and that's because these can sometimes recur. They can either recanalize through the coils or plug, or you can have accessory arteries develop which pass around the coils or plug and basically reperfuse that AVM. But also you could have other AVMs which enlarge, and we want to be able to detect that as well. So that's the other reason to follow with chest CAT scans. My hope, again, is that we can convert to MRI eventually so that we don't have to have repeated radiation exposures as we follow these AVMs. Turning now to brain AVMs or cerebral AVMs, these are a similar pathology, an abnormal connection between an artery and a vein within the brain, and that connection is often fragile and aneurysmal. This is an MRI scan, and here this is all normal brain, but you can see this kind of funny looking cluster of vessels in one edge of the brain, and that's what the AVM is. And this is what it looks like on angiography, where we're injecting contrast on these normal vessels over here, and then this big abnormal fragile aneurysmal vessel here is the brain AVM. It's in about 5 to 20% of HHT patients will have a brain AVM. HHT type 1 patients more often than type 2. And those, unlike the lung AVMs that rarely have any problems in childhood, brain AVMs can sometimes cause problems in childhood, including seizures, headaches, and most worrisome, intracranial hemorrhage. The risk of bleeding from a brain AVM depends on the size and location, but on average it's somewhere around 1% per year. So a little bit less in HHT-related brain AVMs than in brain AVMs in the general population. And for micro AVMs, which are AVMs smaller than 1 centimeter in size, the risk is likely even lower. The exact risk is something we're studying thanks to the Cure HHT Foundation. They've sponsored a study called the BVMC study, which many HHT patients are a part of, where we're monitoring for bleeding and seeing exactly what the risk of these brain AVMs are. Of course, any bleed in the brain can be catastrophic, and so it's best to avoid that by treating these if necessary. So unlike lung AVMs, where we don't tend to do screening tests early in life, in brain AVMs, we do want to find that out. As soon as we diagnose HHT in a child, we will do a brain MRI. And if the child is very young, under 2 years of age, we don't use contrast because there can be sometimes problems related to contrast in small children. But if they're over 2 years of age, or they're an adult, we'll do a contrast-enhanced MRI of the brain. That's very sensitive for picking up brain AVM. For a child, we'll repeat that at least once at age 18. And once you've had a negative brain MRI as an adult, meaning you're 18 years or older, you've had a negative brain MRI, you'll never need another one because new brain AVMs do not form later in life. If you can't have an MRI for some reason, then a CT angiogram is an alternative, which will work just fine. As far as treatment of these AVMs, there's several different ways of treating them, and that's beyond the scope of our discussion today. Just know that some AVMs may not require treatment, but if you do have treatment, one option is embolization, kind of like in the lung, where we pass a catheter into the AVM and block it. Radiation is nice because it's completely non-invasive. You just concentrate radiation on the AVM and shrivel it up. And in some AVMs, the best treatment is surgery, where the AVM is resected. Turning now to our final type of AVMs that we'll cover today, and that's liver AVMs. And these are very common, occurring in about 50% of HHT patients, but probably get the least press of any of the types of AVMs, and we'll get into why that is. For some reason, liver AVMs are most common in females, and they're usually seen in older patients. They can occur in sort of two different flavors, depending on whether the connection is between a hepatic artery and a hepatic vein, which is called an arteriovenous malformation, or between the hepatic artery and a different vessel called the portal vein, which is arterioportal. And this is a CAT scan of what a liver AVMs would look like. It's this massive, this liver here is completely replaced by all these bright areas, which are liver AVMs, and there's hundreds of them filling this liver. And what's causing is massive, massive flow through these AVMs, which can strain the heart and cause heart problems. Contrast CT or MRI can be used for diagnosis of liver AVMs, but we don't routinely screen patients, and the reason is that most patients are asymptomatic and don't need any sort of treatment, so we don't go looking for any problems. Since about 90% of patients are asymptomatic, and those patients, they don't need treatment, but that 10% that can have problems, they can run into problems with things like heart failure from the heart being overworked by these massive liver AVMs. Or in the case of arterial portal shunting, you can have portal hypertension, which is the same problem that patients with cirrhosis and liver disease get, or even rarely problems with the bile ducts. And these pictures on the right are some videos of angiograms, and you can see the difference between the two types of AVMs. The top one is that same patient that had the massive arteriovenous malformations in the liver, and what we're seeing is we're injecting the aorta, and the contrast is going through this massively enlarged liver artery, passing right through the liver, and massive flow back to the heart. So you can imagine how the heart is having to work extra hard to pump all of this blood. On the other hand, this is a little bit different. This we're seeing the blood pass into the portal vein within the liver. It's not passing up into the heart. So this patient is not at risk of heart failure, but they are at risk of liver problems. Treatment for liver AVMs, like we said, usually don't require any treatment, but if they are having problems, then for high output heart failure, we'll start them on diuretics and beta blockers. Usually I'll refer them to a cardiologist. If they're having liver problems, they can be helped by salt restriction and diuretics. If those don't work, then Avastin, which seems to work in a lot of different areas of HHT, it also works in liver AVMs. And the reason is they can shrink and reduce the number of these AVMs in the liver and thereby reduce the amount of flow that's happening through them. And there's been a good study out of France that showed that in patients with severe liver AVMs, it was effective in about 80% of those patients. It reduced the shunting within the liver and decreased the cardiac output. And that effect seemed to be durable for at least 1 to 2 years. And I've used that in several of my patients as well, and it has worked very well in my experience. If Avastin doesn't work, you really don't have too many other options. One is that we can sometimes try doing embolization, but you have to be very careful with that because there have been incidences of liver failure and even death that occur with embolization. And if nothing else really is going to work, then liver transplant may be the only option. Fortunately, I have not had to refer any patients to liver transplant, but it has been reported before. I want to cover and close with a few of the precautionary measures and links to other illnesses in HHT. I get a lot of questions from my patients who are pregnant or planning on becoming pregnant about whether they'll have problems related to their HHT. Unfortunately, the answer is usually no. The vast majority of pregnancies in HHT are uncomplicated. They may see worsening of nosebleeds. That's because your circulating blood volume does increase during pregnancy, and so you may see nosebleeds worsen. Lung AVMs, you really want to, if you're thinking about being pregnant, you need to make sure that you've been screened for lung AVMs, and any lung AVMs that are there are treated before you become pregnant because they can enlarge and rupture with pregnancy. Again, related to that increased circulating blood volume, the increased volume can cause a rupture of the lung AVM and could cause a very severe problem. So we want to screen and treat before you become pregnant. If you are becoming pregnant and you have not been screened, then we will screen you during pregnancy because we sometimes, and in fact I have had to on several occasions, treat patients during pregnancy to help prevent these types of complications. Brain AVMs, we don't really know whether there's truly an increased risk of rupture from a brain AVM during pregnancy. Some physicians believe that you shouldn't have the straining related to a regular vaginal childbirth if you have an untreated brain AVM. Other physicians feel otherwise, that it's fine. I usually let our OBGYN doctors decide on this because there really is no data to suggest one way or the other. So I leave it often up to the OBGYN and the patient as to whether they'll have a cesarean or a natural childbirth. Another big controversy is screening for a spinal AVM. I didn't mention spinal AVMs before in this talk because they're very rare, like 0.1%. So like 1 in 1,000 patients with HHT or so can have an AVM along the spinal cord. And there's this theoretical risk that if you had a spinal AVM and your anesthesiologist went to give you an epidural, that you could have bleeding in the spine, and certainly that would be very catastrophic. It has never been reported. And there has been also a recent study where patients with HHT had not been screened and they had epidural or spinal anesthesia and they did not have any complications. So I don't feel strongly either about whether this needs to be screened for, but some patients and OBGYN doctors do prefer to screen with a non-contrast spinal MRI, and certainly there's no radiation there and very little downside, so that's fine if the patient and doctor choose to do so. As far as liver AVMs, again, with that increased circulating blood volume, heart failure may be precipitated by pregnancy if large liver AVMs are present, so it's something good to know about. Antibiotics are another source of a lot of questions, and there's this theoretical risk of brain abscess from any dirty procedure if you have lung AVMs, and that could include dental work or contaminated surgical procedures, but we don't really know the exact risk. And What we usually recommend, based on the guidelines set by the HHT Foundation, is that your dentist give an antibiotic 1 hour prior to any procedure, which could cause contamination. And usually that's amoxicillin. And what I usually tell a dentist is, if you had to treat my HHT patients with lung AVMs the same way they would treat a patient that has an artificial heart valve. And so usually they know what to do with a patient with an artificial heart valve, and they'll give the same antibiotic to my HHT patients with lung AVMs. If your bubble study is negative, you have no need for antibiotic prophylaxis. Another question that comes up a lot is air filters on IV lines. A lot of patients are told over and over, you have to have an air filter on your IV line. And I do agree that having an air filter on your IV line is a good thing, because it can prevent air bubbles from passing through any untreated lung AVMs. So if you have untreated lung AVMs, it's best that you have an air filter placed on the line. But patients have to also understand that sometimes you can't have filters. For example, if you have to have a CAT scan done and they have to inject contrast, or if you need a blood transfusion, those sorts of things, they can't pass through an air filter. So you have to allow your doctors to do these sorts of things without an air filter in place. And really what's most important, and that patients often don't realize, is that the biggest risk is really when they start the IV, even whether there's an air filter or not. When the nurse starts an IV, sometimes they'll flush little air bubbles into your circulation, and in a normal patient that would cause no harm, but in an HHT patient with an untreated lung AVM, that could cause a TIA or stroke from that air bubble. So I always caution our nurses to not allow bubbles into the IV line, and you should do the same if you're ever having an IV started and you have untreated lung AVMs or even a positive bubble study. You should caution them about that. As far as scuba diving, if you have untreated lung AVMs, they can predispose to what's called the BINS, or decompression sickness, which can be severe. And if you've screened negative for lung AVMs, it's not a concern, but if you do have them, you should not scuba dive. We'll just finish up with a few links to other medical conditions. Pulmonary hypertension is the big one. That's basically refers to elevated blood pressure in the lung arteries. And you can sometimes see some mildly elevated pressures in HHT patients, but pulmonary hypertension, this idiopathic form of pulmonary hypertension, is very rare. Only about 1% of HHT patients have it. It's almost always HHT type 2, which is the ALK1 mutation. You can also get pulmonary hypertension from the massive blood flow that can occur from a high output of liver AVM. So it's a different mechanism, but it can also occur in that subset of patients. The symptoms that you'll usually have is shortness of breath and fatigue, and it's usually diagnosed by an echocardiogram and a right heart catheterization. The treatment is variable and is a little bit beyond the scope of our talk today. It depends on the cause, but you'll be referred to a pulmonologist and a cardiologist, and they'll discuss the proper treatment regimen. Migraine headaches, very, very common in HHT patients, and also common in the general population. Migraine headaches are not very well understood as far as the exact cause, but it's thought to be related to vasoactive substances in the bloodstream. And certainly if you have untreated lung AVMs, those vasoactive substances could potentially pass through your lungs and get to the brain easier. And so that's why it's thought that HHT patients, particularly those with lung AVMs, have a higher risk of migraines. These are recurrent and often severe headaches. They can be aggravated by light and sound, and you may have visual or sensory changes that are associated. About 30 to 40% of HHT patients will have these migraines that often improve when the lung AVMs are embolized. If they don't improve and you still have migraines, then the treatment is just the same as for regular migraines in the general population. Starting on or finishing on a high note, there's a very interesting study that came out recently about cancer in HHT. And basically this was an analysis of hundreds of thousands of patients with various types of cancer, and it compared how did HHT patients survive compared to non-HHT patients with cancer. What they found was that the survival of HHT patients was actually better than non-HHT patients, and it brought up a lot of interesting questions about whether these gene mutations, which obviously we consider causative of all these problems in HHT, like lung and brain AVMs and nosebleeds and all these other problems, well, maybe these same angiogenic factors, these same gene mutations that occur in HHT may be in some way protective of dying from cancer. And we don't know very much about this yet. It's just been sort of an observation that the survival seems to be better. But if you want some good news related to your HHT diagnosis, it seems to be that for some reason the survival from cancer tends to be better than other patients. So something positive to take home from this. So in the end, what does it all mean to have an HHT diagnosis? Well, first of all, it's certainly not a death sentence. The lifespan of an HHT patient should be normal if it's treated correctly, and every patient should coordinate their care with at least one visit to an HHT center of excellence. One thing that I see all the time is sort of a fear of the diagnosis of HHT, and I really advise you not to let this fear of HHT prevent screening for the disease in yourself or in your family members. Even asymptomatic family members should be screened because patients often don't have visible symptoms, especially early in life. Nosebleeds, as we all know, are difficult to control, and different things work for different people. So I always tell my patients not be discouraged. We're going to start with the simplest treatments that are the safest, and we'll work our way towards the more aggressive treatments as we need to. If you have anemia and you don't have really severe nosebleeds, almost always it's from GI bleeding, and you may not even know that you're having GI bleeding, so you should be screened for it. And if it's the case, fortunately there are multiple treatments as we've gone over. As far as AVMs go, everyone should be screened. Brain MRI should be performed early in life to screen for brain AVMs at any age. A bubble study or chest CT should be used to screen for lung AVMs starting at age 10 to 12 and then repeated every 5 years or so. If you have any heart or liver problem, that should prompt screening for liver AVMs with a contrast-enhanced abdominal CT or MRI. And if you need any treatment for AVMs, I would encourage you to come to a center of excellence for that type of treatment. Together, I can say that we can successfully manage HHT, and my hope is really that we can someday cure it. And that's going to take the work of physicians and patients together, as well as with the Cure HHT Foundation and with researchers and PhDs. And I think I'm very optimistic about what we can do to improve the lives of patients with HHT, and I'm very happy to be a part of it. Thank you very much.
Thank you, Dr. McWilliams. That was an incredible overview. And so we do have several questions that span across lots of topics. So I'm sure that everybody won't mind if we go over 9 o'clock by just a few minutes just to get these all in. So the first question is regarding GI bleeding. Is it unusual for HHT bleeds to be acute so as to cause hemoglobin levels to drop very low over a 2 to 3 week period?
I would say it's uncommon, but I have definitely had it happen before. So usually HHT-related GI bleeding is a slow, innocuous bleed where you'll kind of have a chronic anemia. But I have had patients who do have more rapid bleeding, certainly over the course of a few weeks, where their hemoglobin drops more significantly. So yes, it can be, and that would be my first suspicion. If a HHT patient has a sudden hemoglobin drop and their nosebleeds haven't particularly gotten worse, then it's probably from a worsening GI bleed, and I would have that patient in for possible endoscopy and possible other forms of treatment.
Okay. And another question, if a non-parental family member is diagnosed with HHT and a child has GI bleeding, what would be the best next steps for getting that child tested possibly for HHT or getting it approved by a doctor to get the child tested?
Well, HHT, as we mentioned, doesn't skip generations, and so if the child has HHT, it means that one of the parents must have HHT as well, with very rare exceptions where you can have what's called a de novo mutation. It's possible to suddenly have this mutation appear even without either parent having it, but almost always one of the parents will be affected. So the way I would usually proceed would be to ask both of the parents if they've had any nosebleeds or telangiectasias, and if they have, then I would do the genetic testing of the parents and then of the child. Now, if a genetic test has already been done of another family member, then the child could be tested just for that specific genetic mutation. It doesn't have to be the parent that's tested, so anyone else in the family will share the same genetic mutation. So the easiest way to proceed would be if anyone else in the family has had the gene test done and the mutation identified, then the child could be tested for that specific mutation and the diagnosis could be established or refuted.
Okay. And if someone has an AVM on their lip, what is the typical treatment? Is that laser or surgery, or are there other options?
Those are the two main options. One option, if it doesn't bother you too much, is just to do nothing, and eventually, usually these telangiectasias will often go away. because there is some turnover of these, but other patients have them stick around for years. They can be quite bothersome or bleed. I refer them to a dermatologist or an ENT physician. We have both at our center that specialize in this sort of work, and depends on the exact size and location. Sometimes a laser is best, and sometimes a small surgical excision is best. And so I leave that up to the dermatologist and ENT physician. It depends a little bit on size and location. The smaller ones usually better treated by laser, and the larger ones may require excision.
Okay. And you spoke a lot about Avastin and how it can be used for a variety of different HHT symptoms. And some people are saying that they actually use Avastin treatments for liver AVMs, but because it's not FDA approved, it's difficult to get it covered by insurance and can be costly. Have you seen this, and is there a way to overcome that?
Yes, unfortunately, I spend a large proportion of my day calling insurance companies for a variety of reasons. A lot of the things that I mentioned are what we call off-label, meaning because HHT is rare, they don't realize that some of these medications are very useful for HHT, and so insurance companies won't cover them. But they usually will if given enough evidence and enough argument. So what you need is a doctor who will fight for you with the insurance company. And it takes a lot of phone calls and sometimes requires what's called a peer-to-peer, which is where I have a direct discussion with the insurance company's representative, who's actually another physician. I can show them the data and convince them that it should be covered. There are the occasional case where no matter what we do, we can't get coverage, and those can be very difficult situations. In that case, I have had at least one patient who had success by contacting Genentech, which is the maker of Avastin, directly, and they were able to, because they could not afford the drug, and Genentech was able to get them the drug directly. But in almost all cases, I've been able to get insurance to cover. It just takes a lot of fighting. We see the same thing with tranexamic acid, which I use in a large number of patients. It's not indicated for HHT, and so we have to often fight with the insurance companies to use it. And fortunately, we can usually succeed at that, but I have been turned down sometimes.
And do you think that some of the studies that are being done with Avastin in the HHT community, I know there's the one at Stanford, and there will be several different posters done at the scientific conference next week in that regard. Do you think that will help?
Yeah, I mean, Avastin is a very promising drug for the treatment of a wide variety of things in HHT, but I don't think it's a perfect drug, and there's new alternatives that are just coming out, basically that work with similar mechanism, anti-angiogenic, reducing blood vessel formation, but perhaps they don't have to be taken IV. An oral form, of course, would be better, and perhaps something that's not so expensive. So I think these things are being developed, and there's a study that's starting up very shortly, funded by GlaxoSmithKline, that we'll be part of here at UCLA, using an oral alternative. It's kind of like Avastin, but an oral version of it. And there's always new medications that are coming out. So I think that's a very, very promising area, and Avastin has been a wonder drug for certain patients with HHT. But I always just caution my patients to understand that it is a big drug that has some major possible side effects, and we really have to weigh its use to make sure we don't just cause a severe complication in someone.
Right. Okay. So if somebody has a positive bubble study, but the lung AVM does not show on the CT scan, how long should they wait to go back and have that CT done again? Or should they just get it treated? What's their next step?
Yeah, very common scenario. So our bubble studies are positive in about half of patients with HHT, but in fact, probably more like 60 to 70% of patients with HHT will have a positive bubble study, but only 30 to 40% of patients with HHT actually have a lung AVM. So fully about half the patients with a positive bubble study will not have a positive chest CT. So it's a very common scenario. And what we do is we just follow them. There's no reason to follow them with bubble study because the bubble study will always be positive. So we follow them with the chest CT every 5 years. And basically what we're looking for, what it means if you have a positive bubble study but a negative chest CT is that you have a micro AVM. So you have tiny AVMs that are too small to see on the CAT scan. But those micro AVMs could potentially grow over time. So that's the importance of following over time, and we would follow them every 5 years or so to make sure that these AVMs aren't growing into something big enough that needs to be treated.
Okay. Can an MRI screening of a brain AVM be done safely in a patient with a pacemaker?
Usually not. So if you have a pacemaker, it depends on the exact manufacturer. Some of the newest pacemakers may be MRI compatible, but usually you can't have an MRI, and those patients should get a CT angiogram, which is a pretty good alternative using CT instead of MR.
Okay. And we had someone comment that this is a very good overview, and they thought that maybe it was something that new patients should even view before coming to an HHT center. So just wondering if you agreed, and what else should a patient do before their first visit?
Yeah, absolutely. I think the Cure HHT website is a wonderful site that has a lot of information on it. Some of the different HHT centers also have information on their site, including our center at UCLA, and there's a lot of information online, and so I would encourage patients to look at all of that before they come to a center. And certainly, I love having knowledgeable patients. They're often happy that they can finally meet someone who knows more about HHT than they do. So I love it when they're knowledgeable about their disease, and I think it really bodes well for curing this disease in the end.
Okay. Are there any natural remedies that a person could use if they wanted to avoid chemical drugs?
It's a really good question, and unfortunately, we don't know the answer. I'm sure that we know that certain foods are triggers for bleeding. There are probably other foods and natural substances that will help prevent bleeding, but unfortunately, none of those natural substances have really been subject to good scientific study, and so we don't have great answers as to whether that's truly the case. And so, I can do nothing more than to try to tell patients to avoid triggers and encourage an overall healthy diet and avoid blood thinners. But beyond that, that's something that we still have to determine.
Okay. And do you recommend routine colonoscopies for HHT patients? Is there any risk?
So it's fine to have colonoscopy as an HHT patient. HHT patients can have polyps and colon cancers just like anybody else, and so they should have colonoscopy on the same schedule as a patient without HHT, usually starting at age 50. Every 5 to 10 years, you should have a colonoscopy. But if you're not having GI bleeding, then you don't need it any more frequently than anybody else. But you should have it just for your routine screening.
Okay. And so we have a question asking about really about migraines, and asking if brain AVM occlusion typically helps the migraine, or if you have your lung AVMs corrected, does that typically improve a migraine?
Yeah, so usually about half the time, if you have a lung AVM and you have it treated, about half the time your migraines will improve or resolve. But the other half of the time it won't, and that's because migraines aren't completely understood, and they aren't totally just related to this shunting of vasoactive substances. So certainly about half the patients after you treat a lung AVM will have improvement. For brain AVMs, usually there's not such a strong association between brain AVMs and migraines, and so treatment of brain AVMs probably will not affect migraines very much one way or the other.
Okay. And an individual's asking if brain vascular malformation for HHT, does it have to be an AVM, or can you have a cavernous hemangioma and still have HHT?
Yeah, very good question. So in the brain of HHT patients, there can be lots of different vascular malformations, including cavernous hemangiomas, what we call DVAs or developmental venous anomalies, as well as true AVMs. So they are more common in HHT, but fortunately they rarely cause any problems. So it definitely can occur, but it's really the brain AVMs or AV fistulas which are the ones that can bleed and really cause major problems. The cavernous hemangiomas and the DVAs or developmental venous anomalies, although they occur fairly commonly in HHT patients, they usually do not cause any problems and usually do not require any treatment. Okay.
And is there a pain medicine that can be safely taken for migraines? I think in your presentation you had Excedrin migraine. Is that what you would recommend?
Oh, well, yeah, unfortunately, it depends a lot on your bleeding because Excedrin has an NSAID component to it, which means it has a component of blood thinning. So would only work well for patients not having bleeding. Tylenol may work, and there are some specialized migraine pills that are out there, which are available to HHT patients. And I would usually just go through your primary physician, and as long as you're staying away from blood thinners if you're having bleeding, then you can use any medication that in a normal patient that has migraines.
Okay. And what can happen if you get a liver biopsy or if you have liver AVMs with portal hypertension?
Very important point. Glad that it was brought up. Liver AVMs should not be biopsied. In fact, that's one of the bigger problems that we can see. You have a CT or MRI or an ultrasound done, and a doctor who doesn't know HHT sees something that they don't know what it is, and so they put a needle into it, and you have a big bleed. And I've heard of that happening before. So it's one of those situations where you have to educate your doctors sometimes that if you have an abnormality in the liver, make sure it's looked at by an HHT specialist before you let anybody biopsy your liver. So they should not be biopsied. I believe there was a second part of that question.
It was about if you have liver AVMs with portal hypertension.
Yes, fortunately, it's quite rare. If it does occur, we usually try to control the symptoms by using certain medications to help reduce the portal hypertension. And occasionally, Avastin can be useful as well. In a worst-case scenario, liver transplant can be done. But in most patients that have that, it's fairly mild and can be treated with medications, the same medications that are used in cirrhotic patients that have portal hypertension.
Okay. And is there any relationship between mitochondrial disease and HHT?
No, none that we know about. It's two very separate and different disease entities.
Okay. And I guess going back to the liver, that posted a question of asking, could it be a liver AVM be mistaken as a cyst?
That would be rare. Now, cysts and AVMs look very different on imaging, so fortunately, neither of those should be biopsied, but they would look very different on imaging, so they should not be mistaken for one for the other.
Okay. And we'll make this our last question. Are there any dangers of open heart surgery in HHT?
That's a good question, and some doctors are confused about this as well. You know, is there? I have doctors ask me sometimes, okay, if I do surgery on this patient, are they going to bleed to death or something? Well, your blood clotting is totally normal, so you're no higher risk for surgery than anyone else as long as your AVMs are taken care of and so forth. So yes, you could have open heart surgery with HHT, and your blood is no thinner than anyone else. It's just that you have these abnormal telangiectasias and vascular malformations that are prone to bleeding, but your blood itself is totally normal. So I hope that makes sense to you as to why surgery should be totally fine. But you do want to make sure that any lung or brain AVMs are treated so that you don't have, particularly if you're laid up after a surgery, you're immobilized for a long period of time, you could have little clots form in your leg. And certainly if you had an untreated lung AVM, then that would put you at risk for stroke. And so make sure that AVMs are treated, but otherwise you should be a candidate for any type of surgery.
Great. Well, again, I want to thank you, Dr. McWilliams, for donating your time tonight. And I want everybody to please remember that this webinar has been recorded and will be posted on our website at www.curehht.org under the resource tab. And I encourage you to share this with your doctors and with your family members as well. I also want to thank you in advance for completing the post-webinar survey that will be coming to you. And we thank you for attending tonight's webinar. We truly appreciate your participation, and we hope that you enjoy the rest of your evening. Thank you, and good night.